I'd like to welcome Erin Davis to the podium. She's from the Faculty of Health. Erin's going to talk to us about non-pharmaceutical tactile activity interventions for behavioural and psychological symptoms of dementia in acute hospital settings, an integrative review. Thanks, Erin.
Thank you. So I'll just start again. Just to give it the respect it deserves, I'd like to acknowledge and pay my respects to the ancestors and descendants of the lands upon which we work, meet and study today. I'm mindful that within and without the buildings, the land always was and always will be Aboriginal land. I'm lucky enough to live and work on Bundjalung Nation. So my name is Erin Davis and I've worked in health for over a decade. I started as an assistant in nursing in aged care. I then became an endorsed enrolled nurse. I then became a registered nurse, and I now work as a health manager for the Northern New South Wales Local Health District. I'm also a long-term Southern Cross University student, having done my Bachelor of Nursing here, and I embarked on my HDR studies last year. The title of my presentation today is a bit of a mouthful, which is great when you're nervous. It's the title of my first literature review, which is currently under revision with the Journal of Clinical Nursing for publication, so fingers crossed. It's called the Non-Pharmacological Tactile Activity Interventions for Reducing Behavioural and Psychological Symptoms of Dementia in the Acute Hospital Setting, an Integrative Review. I'd like to take the time today to present the findings from this review, but I'd also like to give a little bit of a background on the topic to hopefully highlight its importance and why it's very important to me. I think it's always good to start with a couple of thank yous to my two wonderful supervisors and also co-authors on this review, Associate Professors Christina Agar and Michelle Bissett. I started my postgraduate studies last year. I really had no understanding of what research is or how to do it. Lots of Google searches of what is research, how to do a thesis. I just hope to be able to make a change in the way that we manage dementia in hospital. And they've really guided me through the process from day one. So I'm very thankful. I'd also like to thank the Northern New South Wales library staff. I agree, librarians are amazing. And also the research office from Northern New South Wales too for their time to meet with me and offer guidance. Thank you to SCPA for holding the Praxis today and everyone that worked hard to get us all here. It's an honour to be able to present. It's the first time I'm presenting in this format, so thank you for the opportunity. And last but not least, I'd like to thank all of the wonderful models who were posed for photos and graciously allowed me to use them throughout this presentation. I'm just going to have some water, excuse me. Practice my deep breathing. So I think I'm going to start with a little bit of background on dementia. Some of you, we've all likely heard of what dementia is, but a lot of people don't know just how common it is. So in Australia, in the 2021 financial year, there were more than 93,000 hospitalisations of people living with dementia, and the length of these hospital stays were 5 times longer than any other patient cohort. One reason for the increased length of stay is that for people with dementia, the hospital environment can trigger or exacerbate underlying aggression and agitation, as well as other verbal and non-verbal behaviours. This can lead to distress or injury to themselves or others. Clinically, these behaviours are referred to as the behavioural and psychological symptoms of dementia, the acronym of which is BPSD, which I'll be using today just to be kind to myself. And I'll be using that throughout this presentation to refer to these behaviours, BPSD. So in the acute hospital settings, clinicians very often treat or manage BPSD with antipsychotic medications. The use of these medications have modest effect in some individuals. However, the risk of complications and increased mortality far outweigh the benefits. Instead, non-pharmacological interventions are recommended as first-line therapy by all major international clinical guidelines. Despite this, non-pharmacological interventions remain underutilised and under-researched, particularly in the acute hospital setting. So when used appropriately, non-pharmacological interventions have been found to effectively reduce environmental stresses and or address the underlying unmet needs to prevent the escalation of BPSD. Non-pharmacological interventions can include lighting and noise reduction, treating underlying pain or discomfort, promoting light exercise, playing music, and also tactile activity interventions. So that's what we're talking about today, tactile activity interventions. That term specifically relates to activities that have a tactile component that arouse the sense of touch, and they provide a pleasant or familiar texture and also encourage fine motor function. An example of this is fidget mats, which you may have noticed actually in all the photos throughout the presentations, and they're small mats generally with zips and buttons and things like that to engage the person with. Making sure I'm up to the right slide, good. So this brings me to the aim of our review, which was to review international research on non-pharmacological tactile activity interventions for reducing BPSD in acute hospital settings. To fully explore this aim, we considered two research questions. So firstly, do non-pharmacological tactile activity interventions reduce BPSD in the acute hospital setting? So are they effective? Secondly, what are the barriers and facilitators to implementing tactile activity interventions for BPSD in the acute hospital setting? We focused on non-pharmacological tactile activity interventions as they can be tailored for use by people of varying levels of cognitive and physical ability. They also typically low cost, easily accessed, and can be delivered at the bedside. So to do this, our method, we searched 4 databases. The inclusion criteria was English language primary peer-reviewed studies that evaluated the use of non-pharmacological tactile activity interventions for BPSD in an acute hospital setting. These interventions may have been administered individually or as part of a multi-component intervention. Furthermore, studies were included if the participants had a formal diagnosis of dementia and were over the age of 18. The search identified 880 papers after the removal of duplicates, which I thought was a lot until I heard Kerry's earlier. And that resulted in the titles and abstracts by 2 reviewers, reviewed the 880 papers, and then 103 papers had full text reviews. We also found 25 relevant literature reviews, the reference lists of which were searched for any further studies that we might have missed. And altogether, this resulted in 7 papers that fit our inclusion criteria. And I'm going to discuss the papers a little bit more on the next slide. Our quality appraisal, we used the mixed methods appraisal tool, and that was completed by 2 independent reviewers to evaluate the methodological quality of the papers. The scores range from 80 to 90%, so that indicated that the studies in the review were of moderate to high quality. For data extraction and synthesis, we implemented the 6 stages of thematic analysis by Brown and Clark, which a few of you are probably familiar with. And that helped to identify and analyse key themes across the articles. To ensure accuracy, we reread the articles multiple times and we focused on the research aim until the prominent findings emerged. Okay, thank you. So here's a very condensed version of our summary table. Our articles that were included, the publication dates range from 1998 to 2021, and they were all either from the UK, Canada, or the USA. All studies used a quantitative methodologies. One was a randomised controlled trial. One study did a pre, post, and follow-up. Sample sizes varied from 3 to 29 people. The studies all examine the effect of tactile activity interventions on a range of different types of behaviours, which we do go into a bit further in the report what those specific behaviours were, but mainly it was agitation and aggression. There was one study that reported on one single tactile activity intervention, which was weighted blankets, while the other studies included tactile activity interventions as part of a larger multi-component intervention program. 4 of the studies used a multi-sensory environment. So this involves taking the person into a dedicated room or space, relocating them off the hospital generally. And 3 of the studies were implemented at the bedside at the hospital. A variety of tools were used across the studies to measure the effect of the intervention and behaviour outcomes. There's very minimal overlap in the tools that were used, which made it fun. So our results. For our first research question, do the non-pharmacological tactile activity interventions reduce BPSD in the acute hospital setting? We did find positive effects reported across all studies. More importantly, there were no adverse effects. So unlike the pharmacological counterpart, the studies reported a reduction in agitation, aggression, and inappropriate verbal and non-verbal behaviour. There was also an increase in positive behaviour, such as increased communication and engagement. For the second question, so exploring the barriers and facilitators to implementing the interventions, the answer, we divided this into 2 key themes because they were both very important. Human resources was the first theme, and that relates to the presence of trained staff and or carers to actually provide the interventions. So most of the studies commented that the uptake of non-pharmacological interventions and the successful implementation was greatly reduced when staff had not been adequately educated on their use. The inclusion of families was also identified as an important human resourcing factor. This can help to promote positive social interactions between the family and the person with dementia, and it may also decrease the burden on staff as well. The second key theme we titled The Right Intervention for the Right Person. So this refers to the person-centred approach in selecting the type of non-pharmacological intervention. So anyone that works in healthcare knows that there's a big push towards person-centred approaches these days. So we did find that to be very important. And this just understands that a person's culture, history, identity, preferences, and also abilities impact the efficacy of any one intervention. So our review concluded that tactile activity interventions are effective in reducing some types of BPSD when delivered in a multi-component approach. We also found that strategies to optimise the implementation of the interventions in the acute care setting include staff education, involvement of family, and a person-centred approach. Limitation was noted to be that the tactile activity interventions were generally delivered and assessed within this multi-component setting. So it was really hard to actually isolate the individual effects of the tactile activity intervention. So that's a recommendation for future research. And also, I think we found that the research should explore the burden that including family or carers may place on them, as we want to avoid placing undue stress or contribute to any form of carer burnout. So that's it. Thank you for listening. I definitely invite any questions, but also any feedback as well, because like I said, this is my first time presenting in this format and the first time presenting these results. So
well done, Erin.
Have at it.
Excellent, good, excellent. We've got a few questions. I really love the photographs, beautiful photographs.
Thank you.
Thank you. Thanks, that was a great presentation. Can you describe what they actually do with these beautiful mats that I see, and what the role of the carer would be in a intervention or a session with one of these mats?
Yeah, definitely. So one of the things we're looking into is non-pharmacological interventions that meet underlying unmet needs. So it actually involves engaging with the person and looking at them in the context of their current surroundings and what their needs might be. So for example, although this is, it's a hypothesis and it's anecdotally found to be true that fidget mats sometimes can promote positive interactions. So, for example, if you were to have a patient in a hospital that was crying out a lot or perhaps wandering, you could look at that and maybe try and understand what the unmet need was. So for that person, it might be confusion or loneliness, or feeling isolated. So in that instance, the carer or the staff member would be able to grab a mat or another kind of activity that they know might be effective for this person, sit down and have a conversation. And for people whose communication skills are limited or impaired by their disability, it's just something that they can interact over. So it's definitely not a one-size-fits-all model of care. It's very much person-centred, and it involves a bit of creativity and thinking outside of the box for the carer as well.
Yeah, so I'd imagine there'd have to be some training for sure for that, right?
Definitely. So it's something that we don't, as a nurse myself, we don't receive a lot of education around in university, and ongoing, it's something that we often talk about. But the interventions don't work in isolation. It needs to be something that we need to be able to understand when these behaviours are starting to escalate, so looking for the early signs, and then have the right communication approaches to be able to then help that person and guide them through and try and address that unmet need. If that answers your question.
Thank you. Thank you.
Thank you.
Any other questions? Yeah.
Just looking at these mats, and they're just gorgeous little things. Are they ideally things that the patients would then potentially take home with them and keep, or is it something that's just in the hospital and it just stays there? Or I guess how are these resourced? And then the second question is sort of with that, is it more helpful, I suppose, if these mats are already familiar to the patient, or does that have an effect?
Very good questions, and you're actually setting me up for where my research is going in the future, so that's great. So before I started research, I was actually making these mats, and all these photos are from a previous charitable endeavour that I had for a couple of years, where I made these mats and donated them throughout Australia. I think we made up to about 200 of them with the help of my mum and auntie. And they were individualised for the person. So it was, what are their favourite colours? What's their physical ability? So a lot of love and attention went into them. Obviously, that's not something that's practical in an acute health setting. I'm actually teaming up with the Northern New South Wales Local Health District, where they've had a lot of community groups volunteer their time to make the fidget mats, and also another thing, fidget boards, which are like essentially on timber hardware. And some of those items will go home with the patient, largely because of infection control. So things like this can't be appropriately washed between patients. So we call them a gift to the person. And our hope is that in the future, this is something that will return to hospital with the person, because we do know that people with dementia have quite a high rate of hospitalisation and recurrent hospitalisation. So no research has been done into it, but just between us friends, I'm hoping that the familiarity of this object will then be able to provide a comfort to the person when they come into the hospital the next time.
Awesome. So good.
But it's another area for research that I definitely want to look into.
I think we might have to wrap it up there. Yep. Thank you so much, Erin. That was excellent.
Sorry if I went over time.